webinar, and welcome everyone. Thank you all for joining us this afternoon. My name is Jehan. I'm the national organizer for ADC. It's been a while since we have been with you. A lot has happened since the end of last year. We know we had an election, we wrapped up the census, we had our holiday break, we had the inauguration, a lot of other things in between. We also hosted our first virtual gala in December, which was very successful, thanks to everyone who supported us. And we're back this year, stronger than ever, thanks to everybody who supported us throughout the pandemic last year, financially supporting us, morally supporting us. It was very different to operate virtually for coming up on a year now. But we are very lucky that we have such a strong support system, whether it's our chapters across the country, all of our members, people who tune into our webinars, our board, and of course, my staff here in Washington, DC. So today, I think it was important and pretty expected that we would start one of our first webinars this year discussing COVID-19, the pandemic, and obviously the vaccine that was released late last year. And I know that we have all heard about the vaccines, and I know that there is a lot of misinformation about the vaccines. And we also want to discuss how the vaccinations are rolling out, what communities are being affected by lack of organization or lack of accessibility, and also to clear up any questions that many of you had. We've had an overwhelming number of questions that have been sent in, and we will get to your questions. But first, I would like to introduce our speaker today. We are very lucky to have her with us, Dr. Jehan El-Bayoumi. I'm always very honored to introduce a strong, powerful professional woman to our panel. And we really, really appreciate you making time for us. I know that it is such a busy time for you right now, but this is extremely important for our community. And so thank you very much for that. Dr. El-Bayoumi is the founding director of the Rodham Institute, and she's a professor of medicine at the George Washington University School of Medicine and Health Services. And so without further ado, we are going to pass it on to you. We have a short presentation, and then at the end, we will take your questions. So feel free to post them in the chat box, as well as in the Q&A. And without further ado, Dr. El-Bayoumi.
شكرا and صباح الخير مساء الخير صباح الفل. Good afternoon. I hope that everybody is doing well and that you're all staying safe and healthy. I think what Jehan outlined sort of as the framework for what we're going through collectively and internationally is really been extremely challenging. I can tell you from a clinician standpoint, as well as somebody who's working in the community, we're seeing skyrocketing problems, unfortunately, with suicide and mental health issues. As a result, we're seeing domestic violence, child abuse, people abuse. In some cities such as DC, we're seeing gun violence go up. We're seeing food insecurity. Now it's estimated that about 10% of kids are going hungry. So there are many, many challenges, but I also think that this has laid bare a lot of the inequities. And frankly, COVID is just the latest example. So what I hope to do for the next half an hour or so is give you some facts. I'm going to give you a short slide presentation. I think it's maybe 2 or 3 slides. And then give you an overview of the latest COVID information that I have available. And just before this session, I was just sharing with Jehan, our department and our infectious disease faculty member just gave a presentation. And at GW, we're actually one of the sites for the Moderna vaccine trial. So this is really up-to-date information, including information about the circulating strains, et cetera. And then we're going to give plenty of time to answer questions because there are a lot of questions, there are a lot of myths, there are a lot of fears. So without further ado, Jehan, if you'd be kind enough to put up the slides. So as Jehan mentioned, I am the founding director of the Rodham Institute. The Rodham Institute is named for my patient, who is Secretary Clinton's mother. If you haven't read about her, I would suggest that you do. She's got a kind of a sad story. She was born in Chicago and was abandoned actually by her parents, who put her and her sister on a train from Chicago to San Diego to a suburb called El Hamra. And she was 7 and, her sister was 5. And she recalls eating hot dogs the whole time, because at the time there were hot dog stands right outside, on the train station platforms, and she could get a hot dog while, still seeing her sister. And then her grandparents were also abusive to her. So at age 14, she left / got kicked out of the house. And it was really through the kindness of strangers, she was taken in by this family who wasn't great with her, but certainly better than the other people, that her blood relatives. And they said, look, if you clean house, if you help the kids, with homework, etc., we will let you finish high school. And she did. And so her mother got remarried and said, look, if you come to Chicago, your new stepfather will pay for your education at Northwestern. And she went there, and unfortunately it was a bait and switch. So what I admired about Mrs. Rodham, first of all, when you saw her, you wouldn't necessarily know that she was, the mother of somebody that's a, famous politician. Very down to earth, spoke with everybody, never sort of, just was very kind, but also for being such a smart woman, did not have the opportunity to get further educated. But what she did is that she audited many classes and really, educated herself. She, and actually her daughter and granddaughter and son-in-law, are some of the most voracious readers I've ever seen. So when I thought about starting the Rodham Institute about 8 years ago, I did it for 2 reasons. One, because I have a lot of, especially political elite that I take care of, including the Clintons, the Cheneys, the Rumsfelds, et cetera, and many members of Congress. But also, and I thought it was important to leverage those relationships to do good, obviously not for personal gain, but also to open their eyes as to all the health disparities that exist here in DC. And just to tell you, one of my pet peeves, and one thing that really gets on my nerves, is when the American government has all of these initiatives to educate and train the ignorant people in the third world. And so, as being of Egyptian origin, and many people on this call, if not all of us, whose home countries of origin were occupied, colonized, and still occupied and colonized, such as Philistine, the hypocrisy of that, which of course, with the pandemic, if you will, the silver lining, is that it's laid bare these inequities, and actually with this last administration has shown a lot about the corruption in the government. So that was one reason. The second reason is, as a medical educator in academic medicine, I was dismayed by seeing bright-eyed, bushy-tailed medical students who went into medicine for all the right reasons, at the very end of their training, really objectify the very people on whose backs they trained. And I have to tell you, this was no different what I saw when I went to Egypt for a month to do my infectious disease rotation when I was a 4th-year medical student. There, because of it's not race, it's class. I mean, here it's both race and class. Poor people from the villages were really treated very, very badly. So I saw the same thing. So if you could advance the next slide, please, Jehan. So that's the basis on which the Rodham Institute was founded. Thank you. This is our homepage, and I would invite you to visit it. And so from my parents and from all the days in Michigan, and what I learned is that health equity equals legal justice equals economic justice equals social justice. And it's really one struggle many fronts. And in a minute, when we talk about specifics with COVID, these are all interrelated and actually predict whether you're going to live or die from COVID. Next slide, please. These are our priority areas. And again, I would invite you to visit our site. So youth education programming and workforce development. So no matter what sort of represented, under-resourced, minoritized communities people come from, and obviously the Arab community is no different, we know through numerous studies that the more clinicians and leaders that are at the table and also taking care of patients, not surprisingly, the better the outcomes. I told you that we want to train the current and future health professionals, and then the key part is really community collaboration. So for those of you that are not from DC or at other institutions in DC, we tend to hold ourselves as academics sort of in the ivory tower as being superior. So I like to joke, but this is not a joke. I love pyramids. I'm partial to pyramids, but when it comes to health equity, or really any social justice issue, we really have to put the individual, the family, the community at the core, and we are all spokes on a wheel. Nobody is more important than anybody else. And so in terms of community collaborations, we really believe that the community leads and we are simply consultants. So we see ourselves at the Rodham Institute as being the glue. We connect, we convene, and we catalyze. We don't actually provide any clinical services because actually in DC, 97% of the population has insurance. And yet we are #1 per capita in the country in HIV, in cancer mortality, in end-stage kidney disease, and in Ward 8, our infant mortality rates are the same as Namibia. I'm sorry, as El Salvador and Cambodia, and our HIV rates are the same as Namibia. Next slide, please. Or that may be the final slide. Okay. So I'm proud of the work that we've done since COVID began. We have actually handed out 500,000 of the new 4-layer masks and hand sanitizers. We are really doing a lot of sort of whole family care. And on March the 6th, we're going to have a Ward 8 specific, and people have to show their ID to prove that they are from one of 2 zip codes to actually bring the vaccines to the community, including wraparound services such as food and mental health. Next slide, please. That may be the last one. Okay, great. So we'll come back. So the thing that I want to impart to you about COVID is, let's talk about some statistics first of all. Who is at greatest risk to die from COVID? Well, we know, unfortunately, and hopefully this 2020 census will change that we are never kind of identified as Arabs. There's no place to kind of check off. I think that's changed actually with my brother-in-law, Fouad Fote, works at the Census Bureau, and I know he told me that. But the current information that we have about whether it's race or even the work status or what people do for an occupation is really not available unless it's available in a few states across the country. So the people that are actually at greatest risk from dying are Asian Pacific Islanders. The next group is Latinos. The third group are African Americans, and then Indigenous peoples. But because the number of Black Americans is so high, percent-wise, although the Latinos, of course, are catching up, the numbers of deaths are much, much higher. And we'll talk about why that is. So when we look at some of the issues that have come up and why are the deaths so high, I think it's important to understand the structural and social determinants of health. There's a lot of discussion when you're talking about health equity in terms of access to healthcare and no doctors and communities or no insurance. Well, I just illustrated to you by the example I provided that in DC, 97% of people have insurance. So that's only second to Massachusetts, right? And of course, we know that the Affordable Care Act really helped many more people get insurance. So what are the 80% that actually account for how long we live? Number one, food. Food is the number one social determinant of mental health. Education is they're very high. Right below that is housing, but you can imagine the economic development of a community, the air that we breathe, the food that we eat, the water that we drink, and we know what's happening in Flint, right? So all of these things impact whether people live or die and how long they live and die. So I'm going to give you an example, again, that's specific to DC, but it's really across the country in any urban setting. So here in DC, Georgetown is kind of the rich area, Anacostia is the very poor area. It's about a 10-mile span. People who live in Georgetown, on average, can expect to live 94 years. In Anacostia, it's 66 and a half. 42% of the kids in Ward 8 graduate from high school. So if I, as a physician, could basically get all the kids to graduate from high school, guess what happens? Their life expectancy increases by 10 years. So we can close the gap from 27 to 17. Why is this important to us as Arab Americans? I consider myself African Arab. Why is that important? It's important because when we translate that to Yemen or Iraq or Palestine or Egypt, right? Lebanon, where systems, Syria, where systems are being, I believe, deliberately attacked, right? And there are huge wealth inequities. We can understand then why there are such big gaps in life expectancy, right? We know this, we see this. So everything that I'm going to say, please put on the hat of domestic and international, because really these inequities have happened. So when we're talking about vaccine distribution, the vaccine distribution is really not right now based on disease burden or need. It's actually, or death rates. It's based on numbers. And so everybody gets the same numbers, which is not equity, right? That's just equal distribution. It does not mean equity by any means. And so in a Ward 7 and 8, which have about 150,000 people, and I believe Ward 4, those are the highest death rates. 84% of African Americans in DC account for 84% of the deaths. And DC is 7th per capita in African American deaths in the country. So let's talk about COVID. Why has COVID-19 been such a killer? Well, COVID, and the 19, by the way, refers to the year it was discovered, okay, when it was first discovered. So COVID is from a family of viruses called coronaviruses. And we've all been exposed to coronaviruses. That's one of the reasons that we get the common cold. There are thousands of those kinds of viruses that circulate, and usually they're harmless. We feel bad, we don't get as sick as with influenza, but maybe it's an excuse to stay home and put our feet up and get a mental health day. But and of course, all the kids whose immune system has not, developed, for any of you that either have young kids or recall having young kids, they bring home everything, right? From nursery or daycare or kindergarten. So what was unique about this particular virus? Well, this virus, first of all, it jumped from a bat to a human being. So there are several cases with this type of virus that originates and basically kind of coexists with various animals, but it causes death and disability among humans. So another example of that is MERS. This was the outbreak that happened, I want to say maybe 5 or 6 years ago in the Gulf, and where it was a camel that jump happened from. You've probably heard of SARS. That was the avian flu, and it was from, I believe, ducks that it jumped from. And one of the theories around HIV is that it also jumped from a host animal that's, pretty healthy and doesn't die from this disease. So with COVID in China, there are these huge markets of many animals and livestock including bats and snakes and so forth. And so, and people actually live with these animals. That's how SARS actually became an issue, because people sleep next to the chickens, right? Or sleep next to the camels, or whatever the vector or the virus is. So that's how it jumped. And then we know, and this is true, that unfortunately China was not forthcoming about this virus and really did not permit the WHO to come and really do some investigation, but allowed Taiwan to. And this is why Taiwan was really able to implement all of these safety measures of masks, as well as hand washing, as well as physical distance. And as Jehan and I were talking before we started this webinar, I think culturally, East Asia is much more comfortable with covering. If you've ever gone to Japan or watched TV, right, on or films, you will see that a lot of people are covered. And there are also lower rates in Africa. It's very interesting, including Egypt, which I find very interesting because everybody's on top of each other. And there are many theories for why that is. And it's not just that masalan, the Muslim women cover their mouth or whatever. No, it's theorized that there are different types of genetic, what we call haplotypes related to blood in Africa, including Egypt and North Africa, that are different than in Asia, and including, Sham. I'm going to show my ethnocentricity here. Egypt, we call all the countries to the right is Sham, and all the countries to the left is Maghrib. That's it. And we're so self-centered and Masr Dunya that we think that Egypt, the sun rises and sets on Egypt, which I'm not going to dispute. But anyway, going to the virus, the other thing that has made this virus so deadly is that we've never seen it before. Okay, but what does the virus do? This virus is very, very sneaky. It gets into our immune system and we don't recognize it as being foreign. It comes in, and so, we're just kind of going along, and depending on our age, our health status, okay, we can die from it. So if you notice, although there are deaths in children, they're not nearly, alhamdulillah, as many as there are in adults. Although the South African, I believe it's the South African variant, there are now 3 variants, which I'll talk about shortly, is actually causing an increased death level among kids, which is really upsetting. I mean, it's upsetting for everybody, but particularly for children. So the thing about the COVID, it's like a ball. It's like, those balls that are spiky balls, that, they're plastic usually, and kids play with them, Well, the spike is the infective agent. So it goes in, sneaks in, and if you're older, what happens is that it overwhelms the system. It gets into your lungs, it can get into your heart, it can get into your brain, into your kidneys, into your liver, into your skin. It can cause blood clots, it can cause strokes and heart attacks. It can really do big damage. Who is at very high risk from the standpoint of diseases? People who are chunky, because their lung capacity is less. So since it primarily hits the lungs, that puts them at risk for death. Number 2, people with poorly controlled diabetes. So if you have diabetes and your A1C, which is the measure of what your glucose has been running for the last 3 months, is less than 7, your risk of having a complication from COVID is really no different than somebody who doesn't have diabetes. So because people, when they hear these numbers, they freak out, because a lot of people, the older you get, the more likely you are to have these conditions. Same with high blood pressure. If your blood pressure is controlled, then your risk is the same as everybody else, okay? So that's number 1. Why do young people, you hear about the young people who are otherwise completely healthy, why do they sometimes die very, very quickly? Well, young people, and maybe we can use this as a metaphor, when they react to the virus, their immune system is so robust that actually what kills them is not the virus, it's the body's reaction to the virus. So what happens is that the lungs are flooded with all these cells that usually sweep up any foreign invaders, right? So they just are, just overwhelm the system. And so then you see young adults or adults that don't have any pre-existing conditions die. Well, why are people in nursing homes at risk? Well, they're at risk because they're all together, they're confined, they can't move. But I'm going to tell you another example, which I think is very interesting, which speaks to the importance of ventilation. And that's why families that are especially multi-generational and all cramped together are at risk. Well, they found out that hockey players were getting outbreaks of COVID. It's like, why is that? I mean, they're healthy, they're in good shape, they usually don't have any chronic disease. Well, it turns out when they are playing on the rink and come and sit down, because the ventilation is great there, right? When they sit down, they're all breathing the same air. So that's how the COVID gets transmitted. We also know that COVID can be secreted in the stools, right? So if there are problems with the water supply and the lack of, of adequate hygiene, not hygiene, but sewage purifying water systems, that can be another thing, which in the developing world, okay, that's an issue, right? I mean, for Palestine, for Gaza, for Dafa, I mean, these are real issues. And P.S., okay, I'm going to be saying this over and over again. When we talk about inequity of vaccine distribution here in the United States, I'm going to tell you, I'm on a number of these webinars. I also do webinars, and always Israel is the #1 model of vaccinations, but what they leave out is Palestinians don't have access. Okay, none. Not to mention in usual times, the health and the ambulances and all the things. So again, you can see how, with Palestine and now sadly with Lebanon and Iraq and Syria, and for a long while, not because of war, Egypt, these social and structural determinants of health determine outcome, right? Because rich folks like Trump, right, when he got sick, and he was very sick, first of all, as president, he was essentially getting, hospital care in the White House. And then he went to the hospital and he got the monoclonal antibodies, which at that time, only 20 other people in the world had received. So your class, okay, which is tightly tied in this country to your race, but other factors as well, determines how long you live. And I want to just also speak, because I'm not going to get caught up in just very narrowly defining people, because we've got multiple identities. So if we look at Masalan sanitation workers, or people who, drive the buses, or people who work and check us out at the grocery stores, it's interesting in DC, they're not considered frontline, although I don't know how we would get along if people don't pick up the trash. To me, that's incredibly important, right? As unfortunately Lebanon has witnessed. But they are called essential. I'm not sure what the difference is. So when you look at the way that they're being screened or have PPE or protective gear or get the vaccines, none of them have gotten vaccinated. And yet the death rates are up. So by the way, Jehan, as we're doing this, I think it would be really helpful if the various ADC chapters look at how this is affecting the Arab community, okay? Because I'm sure there are going to be pockets. I'm sure there are pockets that people will do very well, right? But then there are also pockets. And I'd really like to see the ADC connect the disparities in the various marginalized, minoritized communities, especially with Palestine and all the countries that are, experiencing war and economic inequality. So you then see that, I forgot my train of thought, please remind me. That's what happens when you get older and you go off tangent.
You were talking about how, sanitation workers are not considered.
Yes, oh, thank you, thank
frontline.
you.
Yeah.
Thank you. So what you see is that people who are poorer, okay, get hit several times, they don't get the PPE equipment that they need. They don't have the luxury of, like me, I can do even my visits on telehealth, teleeducation. They can't telecommute, right? I mean, they can't, they're just not offered that as an option. They either show up, they lose their job, and then people can get hired because of the unemployment, right? Again, there's lots of similarities with the developing world, right? It's the same sort of oppressive system, if you think about it, very similar. So we then talk about the people who are vulnerable. We talked about the occupation, but let's talk about other marginalized or minoritized groups, because there are minorities within minorities. There are the disabled, the deaf and hard of hearing, the people with mental illness, returning prisoners, undocumented immigrants, who am I forgetting? LGBTQ, seniors, right? Because eventually we will fit into one of these categories if we are lucky with the seniors, right? So, it's important that we understand, because I think there is a lot of sort of blaming the victim, whether it's here or abroad. People who are poor or who are under occupation, whatever sense, have competing priorities. So if you have to take care of your grandmother, you've got 3 kids that are having to, do tele education, which some may not even have internet. If you've got to go to your job, all of these things, you stratify. Right? You stratify. So people are actually really smart. They say, okay, me getting food on the table is more important, because guess what? My immune system will be more robust and I won't be as susceptible. So going back to the COVID virus. So now we're talking, we've moved into, alhamdulillah, the actual vaccine. So let me tell you what a lot of my patients ask. They say, well, for the ones that are reluctant to take it, I'm really nervous that it went through and got, approved so quickly. And that, of course, is not just about the time, but I think it reflects the distrust that many people have with the previous administration. So what I like to tell people is that actually this technology has been around for 10 years. And the part of the virus that they're using is not the whole virus, it's just the spike protein, which is the one that causes problems, which is actually good news, because if those variants, if the vaccines don't protect against these variants, it's actually pretty easy to get whatever the South African, British, Brazilian variant is, to just isolate that protein, that protein, that M spike protein, to create vaccines, and it'll be a lot easier to do that. So, but I also tell people that I have a colleague, you may have seen him on CNN or MSNBC. His name is Dr. Peter Hotez. He's an infectious disease researcher. He was this close to creating a COVID vaccine back in 2016. Of course, it wouldn't have been this COVID, because that's new, but it would have really incorporated what was known about COVID at the time. And that previous administration cut off his funding. So why did it happen so quickly that this vaccine was approved? Well, it just illustrates to you, when there's international cooperation for the common good, how quickly we can solve complex problems, number one. Number two, because so many people were sick, the people enrolled in clinical trials, as opposed to other medicines or other treatments, including vaccines, it wasn't just like 1,000 or 2,000. No, we're talking about tens of thousands of people. So that's where we could get the safety data, and inshallah, we'll have the vaccine available for kids by the summertime, because we obviously have to be extra cautious with kids. And then we'll have more data about pregnant and nursing mothers. Okay, so that's another sort of myth that I want to make sure that we cover. Now, just real quick to treatment, because we want to leave time for questions. Treatment. So first of all, we've done much, much better in preventing death than we were at the beginning. I don't think that you see those scenes of of New York or Italy or Spain, alhamdulillah, because what we've learned is that it's actually not a good idea to put people on respirator. So if somebody needs to be hospitalized, they need to sleep on their tummy. We also know that there are tests one test called the D-dimer that can predict whether somebody needs to be put on a blood thinning agent so that we can prevent the complications of stroke and heart attack, as well as gangrene and loss of limbs. We also know that monoclonal antibodies work. And just like vaccine distribution is not equitable, not everybody has access to the monoclonal antibody, but moreover, they're not even offered monoclonal antibodies at institutions that use them for other people. There are a lot of medicines that don't work. We now know that hydroxychloroquine doesn't work. We also have heard of ivermectin, which is used for parasitic infections. That doesn't work. The data on vitamin D and zinc and vitamin C has been mixed, but probably because poor people don't have those nutrients. So it's a little bit, it's an association, but not necessarily the cause of increased deaths. But another medicine that works is remdesivir. So I think I'll stop there because that's a lot of information to digest, and we want to make sure that we get to your questions.
Thank you so much, Dr. El-Bayoumi. I agree with everybody that's been posting comments that everything that you're saying is so informative, and mashallah, you are an amazing speaker. I could probably sit and listen to you all day. I get bored with medical stuff, I'm not gonna lie, but everything that you've been saying is so fascinating, and I think it's very important that we make the correlations with what we're seeing with other marginalized communities and what we ourselves are experiencing in our own population. And like
I'm going to stop you. I'm going to stop you. Masreya, Masreya, Masreya. All of us talk like this. I'm not unique. Saddaini. Millions of people are just like me.
Yeah. Well, I mean, you're great. You're really good.
Thank you.
So I mean, for us, I think it's important that we're, making these correlations. And so I know a lot of people have had a lot of questions, and some people have posted some things in the chat box. So some of them are pretty basic. So someone posted about the nursing mothers, and I think you touched on that, right?
Yes,
so,
I'll be happy to come back to that because that's an issue that actually prevents a lot of women from getting vaccinated. So I would say this, if you are thinking about getting pregnant, it is better to get vaccinated beforehand. And let's not forget the role of fathers, because people always assume everything is the mother. But remember, viruses and other toxins such as alcohol or other illnesses affect the quality of sperm for 3 months.
Okay.
So if somebody was sick, if a potential father was sick, you want to just wait. And actually, it's also good that he gets vaccinated. So the data on pregnant and nursing mothers show that they're at higher risk. But if you nurse the babies, both you and the baby have much higher protection. There have been a few case reports of babies getting transmission of the virus, through the mother baby transmission when the baby's in the uterus. And there have been death rates. But remember, pregnant women, especially after they deliver, are at high risk for blood clots. So again, we don't know sort of what the association is versus the causation. Is COVID causing it? But these are things that it's important to be informed about so that when a woman is, just given birth, and 40 days, by the way, is the magic number, that she's at risk for developing clots. And, in Egypt, certainly, and many other countries, a woman is confined to home. They call it confinement. So that's actually not a good thing unless she's getting some blood thinners.
Okay, wonderful. Thank you for that. Okay, so someone wrote, can everyone, including people with comorbidities 2 weeks after the second vaccine dose, travel by plane and train?
Very good questions. In general, the answer is yes. It takes about 2 weeks for the antibodies to fully kick in. And so what is likely going to happen, and that's why I would recommend for anybody that's vaccinated, laminate the card, because it's going to be just like any other document, Social Security, passport. It's likely that we're going to have to show these as proof of vaccinations. And these are not just a doctor signing off. They have the lot number, the date, and it's very, very strict. So you can't, I don't think there's a black market yet, but I wouldn't rule it out. I'm sure there will be. I think the important thing to realize about travel, because this just happened to a colleague, she was actually in the Moderna trial and got the COVID vaccine and then went to India and got COVID.
Oh.
But the important point there is once you're vaccinated, even if you get one of these other strains, you don't die from them. So she was sick and she got fatigued and she was able to spend more time with her family and before coming back. So just to tell you, there's a lot that we still don't know. We also know that as you get older, your ability to mount an antibody response to the vaccine, whether it's the flu or shingles or whatever, is not as robust. So there's also already talk about, do we need to do a booster? So lots of great questions. We just have to kind of wait and see. Because we're doing, if you think about it, we're doing a real life kind of thing. I don't want to say experiment because it's not an experiment, but we're really tracking, we're tracking population data in real time.
Yeah, absolutely.
And I should say this, that's why it seems like there is contradicting information from the medical community, whether it's CDC or Dr. Fauci. It's not that it's contradictory. It's just like you should change your opinion or recommendations based on science and data.
Right. Absolutely. Yeah. I mean, like I was mentioning before, there's so much misinformation that's very easily transmitted with social media and like WhatsApp groups. We really, people should be talking to their families and, showing them, real information about what the vaccines are. So another question that I think a lot of people have in the back of their mind, someone posted, I'm hesitant to take the vaccine because it's still new. And
Yes.
I'm waiting for Johnson & Johnson vaccine because it's a typical vaccine. So in your opinion, is there a difference between all the vaccines? Is there one better than the other? Should someone wait? Give us your opinion on that.
So great questions. So the Moderna and the Pfizer are equivalent. And they do afford protection against these 3 new strains, which are much more infectious. And as I was mentioning earlier, seem to be more deadly among kids, especially. The Johnson & Johnson, the report was issued, and it may have caused stocks to plummet, is that it really does nothing to protect against the more virulent circulating strains, such as South African, the British, as well as the Brazilian. So, look, it's better to get vaccinated if there are shortages with something, to have something. But if there is the choice, which states are getting either Pfizer or Moderna through the government, either one of those are fine. And again, just to go back to this newness, because I think a lot of people are hesitant just because of that reason. Again, the technology has been around for 10 years. And I would just say this, this is what I tell my patients, who's dying of COVID? I actually think, and people say conspiracy theories, but passive genocide. I mean, it was articulated. Remember when they were saying, oh, well, 70 is old enough, or people with chronic conditions, or people are not dying from COVID, they're dying from diabetes. So my friend Mona Ayesh, Palestinian, she said, that's the same argument as if somebody was in a plane with diabetes and it crashed, you say they died from diabetes. I mean, it makes about as much sense. And then there are also the fears of, some fears, like the Nation of Islam has said that you're going to be tracked and so forth. I hate to break it to you, we're already tracked.
Absolutely.
Social media, your phones, Google, if you look at one site, all of a sudden, all this stuff and advertisements come up. And then, is it going to cause cancer? The air that we breathe, the water that we drink, the food that we eat, there's a lot of cancer causing agents. So again, it's risk assessment. So.
Yeah, absolutely. Somebody posted in the chat box, is there or should there be a system to log the cases of Arab Americans, incidents and outcomes related to the vaccine? Is there anything that
Absolutely.
you know that's in the works? I know in Southern California, there's Dr. Rodham, who's been kind of keeping track of COVID, actual people catching COVID, and now maybe, how many people are getting the vaccine and what reactions they have, specifically for the Arab community, but I'm not sure of anything else in the country that's doing that.
As far as I know, no, there is no data collection. And I believe that's where ADC can take and champion this, okay? Not just for Arab Americans, but other people who, quote, don't fit in the, excuse me, racist paradigm, right?
Right.
Number one. And then number two, as far as I know, there's nothing that looks at level of education or occupation or things like disabilities and all the other factors that we basically mentioned earlier.
Right. Okay. Yeah, that's definitely something to look into doing, because obviously we think it's important, especially because we don't know what the census outcome is going to be in terms of us getting our own box, but we're in the middle of this pandemic at this moment. So it's important for us to have factual information on how this has been affecting our community.
And, just to tell you, as I believe, maybe as of last week, this may have changed, so please trust but verify. I believe that only 22 states and the District of Columbia are even reporting race, ethnicity information.
Okay. I mean, I think that that's important. And like
Yeah.
here in DC, like you said, I mean, we're seeing a correlation between the very heavily Black and brown populated areas with a higher incidence of COVID infections versus them having the lowest number of people vaccinated.
Exactly.
And it's very mind-boggling to me to be able to see these maps just 100% overlap. Where one is, excelling in COVID infections, it's the lowest in vaccinations, and vice versa with the predominantly white, wealthy neighborhoods in DC.
Yeah, Habibti, where I live, which is in Ward 3, there's only been 5% of the deaths that have come from Ward 3.
Oh, wow.
Yeah.
Yeah.
But again, just to remind everybody, this is true of every other urban area. I'm using the DC example because I live in DC. And many, as we've mentioned before, other countries, including Arab countries, right? Except I want to say for UAE, Al-Emirat, because they actually have been touted as one of the places where they vaccinate pretty well.
Right. Somebody posted a question. Actually, we got it a couple times. If you test positive for COVID, how long should you wait until you get vaccinated?
Great question. I've actually also been asked if people should get vaccinated at all if they've had COVID. I've had many patients who've had COVID asked to get the antibody test to show that they have antibodies. So we do have scientific data on that. And you should get vaccinated, absolutely, because you have more protection. And as I mentioned, the vaccinations, even though they don't protect against the strains necessarily, they do reduce death and disability from COVID. So that's one reason to get it. In terms of the timing, I would, you want to try to mount the strongest antibody response. So first you have to be symptom-free, and you should talk with your doctor, because remember, we talked about the other factors, right? Like diabetes and high blood pressure, and making sure that you have maximized the control of those so that you can mount the best antibody response, including, by the way, nutrition. Because when people are sick, they may not be eating as well, right? So you want to make sure that all of the micronutrients have been repleted.
Yeah, absolutely.
So that could vary. It could be 2 weeks, it depends, versus maybe closer to 6 weeks. And again, I would recommend that people go to the cdc.gov website, because as new information or more scientific data is available, some of these questions can be more accurately answered.
Okay, very good. Okay, so someone asked if someone is allergic to certain medicines like sulfate. I mean, I'm allergic to sulfate, or other things, or if they've never gotten vaccinated, like if they've never gotten a flu shot before, should they still get this vaccine?
The answer is yes, but I'll tell you who should not get it. Okay.
Okay.
First of all,
Probably
there are a
good.
lot. Yeah, there are a lot of people with allergies. Okay. Whether it's peanut or food allergies, people can absolutely get it. And then unless you're coming directly from another country where they don't vaccinate routinely, everybody's gotten vaccinated, right? Because you have
Yeah.
your childhood vaccinations.
Right.
And you're required to have your tetanus, I know, for immigration, right?
Absolutely. Yeah, like
And
every
then,
10 years or something.
right. And then in another theory about why the death rates are less in Africa is because of vaccination with BCG. So people have gotten vaccinated. They may not have remembered it or whatever. So that's number one. The people who should not get vaccinated are the ones that have had a severe allergic reaction to a vaccine. What does that mean? It means unable to breathe, tongue swelling. So, we all get some kind of vaccine to the vaccine. We have some reaction. There are some that cause more of a reaction. Anybody who's had a tetanus shot can tell you that their arm kills for, a few days, and you feel like, you've gotten, hit by a train. Those of us that are old enough to get shingles vaccine also know that the arm gets pretty red.
Yeah.
You can even run a low-grade fever. So the two conditions, that I am aware of, but again, go to the CDC, talk to your doctor or your clinician, nurse practitioner, PA, to make sure that if there is an allergy, again, medicine, even bee stings, insects, or food have not been shown. And I just want to also say, in terms of vaccine safety, the data right now, 9-month-old data, it's actually a lot less than other vaccines, significantly less in terms of side effects or vaccine reactions. And then remember, you're getting these vaccines in settings which you are required to have medical personnel on hand. So you actually have to sit for 15 minutes. And for people who have conditions, you have to sit for longer. And I saw just on the chat out of the corner of my eye, somebody asked, can you take shingles and COVID? You actually can't do that because, again, you want to mount the best antibody response. I think we recommend maybe a month or even 6 weeks in between vaccines.
Okay, that makes sense.
So COVID is the priority, right?
Right, yeah. Now, a lot of people have asked, how long after you get your second dose? Basically, what's the timeline after you get the second dose for it to reach like full immunity or the actual, vaccine to take?
Protection.
Yes, exactly. Because someone's saying that they're going to be traveling the day after they take their second shot.
That's not going to be enough time.
Right, of course.
So,
which they recognize, but they just want to know.
No, of course.
Yeah.
So again, it depends on how robust your immune system is, right? So we say generally in the 2-week time frame, but you can imagine circumstances where it may take longer. So that kind of discussion should really happen with your clinician so you can see sort of which group you fall into. And again, remember that being vaccinated is not 100% guarantee that you won't get COVID, but your chance of dying or having significant complications really falls significantly.
So that means that people should continue to mask up and continue to social distance when they can, which is something I just wanted to say, because a lot of people feel like if they get the vaccine, then they're free and clear and they can just go and do whatever they want. And I just want to make sure that you cannot.
And then and if I could also add, people are not going to like this. I certainly don't. We now have to use double layer masks because the new strains are at least 40% more infectious. And as I mentioned earlier, maybe more deadly. So what does that mean? Does everybody have to go out and get N95s or K95s? No. But you do have to, if you can get just like the masks that we wore before COVID in the hospital,
the surgical ones, the blue.
The surgical masks, the blue ones. You can do that double, or if you have a cloth mask, you can double mask. I mean, but it's horrible. I mean, in the winter, it's not so bad.
Right.
But
it's
let me
actually
tell
kind
you,
of nice to warm you up.
But let me tell you, when I'm on the phone and I'm walking up a hill, and have double masks, احنا بنقول نفسي هيتقطع. I mean, I can barely stand it.
Yeah, absolutely. No, I totally agree. But I think it's important that people realize there's, still a lot of precautions that we have to take.
For
we
sure.
need to achieve herd immunity too as a country. It doesn't matter if you've been vaccinated. If people around you haven't been, then people are still passing around this virus.
So you brought up herd immunity. I want to just comment on that because that was mentioned a lot by the previous administration as a way of just let everybody get infected and eventually. Well, that's true. I mean, I don't want to say that's untrue. There may be 1 million deaths and it may take a year or even 2. So herd immunity is when you have, and I think Dr. Fauci's last estimate that at least 80% of the population has to be vaccinated before other people who may not be able to get the vaccine for whatever reason are protected. So let's use a different example than COVID. So everybody has heard about the measles outbreaks that have happened in the country, and they tend to happen in areas where there are strong anti-vaxxer communities. And so what happens is that the herd immunity, because of vaccines, fall. And then if there's one case of measles, then it spreads through the community.
Again, yeah, it's true. Okay, so many questions. For people who are raising their hands, just put your questions in the Q&A box because we can't put anybody to speak live. Okay, so that one. Someone said, I heard it would be wise to create an immunity bubble. So I guess kind of like how everyone has been putting together their own small pods of groups of people that they've been hanging out with.
Yeah.
Like here in DC, all my friends and I, there's like a group of literally 4 other people and me. We only hang out with each other. We do a lot of outdoor dining if we go out, but usually if we're inside someone's house, it's literally just us. Just to be very safe and still wear masks and sit outside on balconies if it's warm enough.
Yeah.
But
let me just sort of acknowledge something that I don't think gets enough attention. This whole pandemic, I think for children and young people has been horrible because people are missing graduations, they're missing big milestones, parties, certainly trips. It's also hitting the elderly who tend to be more socially isolated. And just to give you a statistic, do you know that being isolated is the same, and being lonely is the same as smoking a pack of cigarettes every day?
Oh, I'm sure.
Yeah. So these are really things that have impacted us. And that's why I'm so glad that this current administration is trying to vaccinate as much as, people as possible so we can get kids back to school.
Absolutely.
But I think what you mentioned as a pod, I think is important. The problem is when somebody comes into your pod. And what I would recommend, if you think you've been exposed, you've got to isolate, quarantine for 14 days. If you get tested right away, it's actually not going to be helpful unless you're already infected, because it requires at least several days before your viral load is elevated. And then don't forget that the type of tests that are used also vary widely. So, those outbreaks at the White House, they were using the Abbott test, which has a 30% miss rate.
Oh my God.
Yeah. You know why? Because of the not just nepotism, but the favors that the administration was showing preferentially to certain corporations. But anyway, that's a whole other talk.
Yeah, absolutely. Yeah, I mean, honestly, I think it's just to be safe, you should probably stick with people within your own household.
Yeah, exactly.
As they've been recommending for quite a while now.
But if I could just say this, if one member of your household is going places, like if somebody works, in the various occupations that I mentioned, they work in a store, like many Arab Americans have restaurants, or they have, stores where they sell delicious kunafa and all these other foods. I mean, that's actually, they could come to the household and they are isolating, but they would have actually brought in the COVID.
Right, exactly. Okay, someone asked to clarify two things that were addressed earlier. Exactly, like timeline of being vaccinated after being infected with COVID, 30 days, 60 days, 90 days. Is there like a specific, wait a month after you test negative, wait till the antibodies are out of your body?
These are excellent questions, and whoever has been asking these groups of questions should go into science and research, because that's exactly how a scientist thinks.
Well, it's a doctor, so.
Oh, see, there you go. Well, I'm sure there are lots of people who are not doctors and scientists that think as well in this way. You don't have to be either one of those. But good questions. The true answer is we don't know. But as I mentioned, we want to make sure that at least you're not symptomatic from the virus, because what that reflects is that the viral load has come down.
Right.
But as we mentioned, it should be tailored. That answer should be tailored to the individual, because if they've got any chronic diseases, those have to come back under control. And then nutritionally, they have to be sound. And also, by the way, let's not forget sleep and mood, because that affects your immunity and hence, how you can respond to the antibody, to the vaccine, and you want maximum. I'll give you a short example, which is kind of cute. When people fall in love, their immunity increases, but when they break up, it goes down. So, that holistic lens is so important. So, great question. I want to say 4 to 6 weeks if we're talking about the population. But again, I would refer you to cdc.gov, because this information gets updated. They're very good about updating it. And it's simple to read language. It's not too much, doctor speak or science speak.
Yeah, it's meant for the general population to read and understand. And then, can you have a COVID vaccine if you have an allergy to the tetanus shot?
It depends on what the allergy was. If it was just a skin reaction, then yes. But if you can't breathe or your tongue is swollen, definitely no. I will tell you that people think that they've had an allergic reaction to tetanus, and it's actually not. It's just a local reaction where there's pain and it's red and it's low grade. That is actually telling you that your immune response is actually reacting. And for the COVID vaccine, I should tell you, whoever's getting their second dose, I thought I glimpsed that in the chat.
Yeah.
You may have more, fatigue, because the first one kind of primed your immune system. And then now that the immune system recognizes that spike protein, it'll say, okay, I see you. And then it mounts a really robust antibody response. And people can have fever and you can take Tylenol, but you need to rest. Yeah.
Okay, wonderful. Okay, so I'm going to ask one last question to wrap this up, because we went a little over just because we started a little bit late, but I want to respect your time. These have all been great answers and the conversation's been absolutely incredible. Do you think anytime in the future we're going to take off masks? And I know we're never going to go back to normal, because I can't personally see myself getting on a crowded train in DC anymore without a mask. I cannot believe we used to do that, like face to face, like smush. I mean, it's incredible, and it's funny because someone said this the other day. They realized that they did not get any colds or flu this year.
Exactly.
And it's because we've been wearing masks.
Exactly.
And it really does work. So it's like, I might just have to continue to wear masks after COVID. So, because I used to get the flu every year. I don't get the flu shot, but I used to get the flu every January, just like clockwork. And nothing,
Yeah.
I mean,
and also don't forget that people are not smoking or doing shisha, or at least,
no one's sharing things. Yeah.
Exactly.
That's very true.
So,
it's very true.
I wish I could say soon, but I would guesstimate the fall.
Which a lot of people have been hearing. I mean, I guess that makes sense. Majority of us know that we probably won't be able to get on the list to vaccinate until like early summer.
Yeah. And so although the administration just purchased 200 million doses, and they're really, as you saw, their goal is, I think the goal of the president was to vaccinate 150 million in the first at least 100 days, or maybe even less than that. So But I'll just want to close by saying we will get through this, and especially for people who have survived war or who have immigrated or gone through, difficult circumstances and are still going through difficult circumstances, I would advise that you reflect back on what got you through.
Yeah.
And trying to stay connected with the people that you love, and make sure that you're sleeping and resting and paying attention to your mental health and your nutrition. We will get through this. We as human beings are resilient.
Yeah.
All of us, no matter what background that we come in, we will get through this. I believe that things will be a little bit different. And when we come back, and actually, I think some of it will be good, because we now realize that we don't have to be in the office. We realize that we don't have to commute. We realize that actually, you know what, it's a good thing to spend time with the family.
Yeah.
So that,
Absolutely.
especially parents, man, they run around all over the place to try to get their kids here and there and everywhere. And I think also that we will value our teachers a lot
God, yes.
They
Mm-hmm.
should
Shout out
be
to all those
paid,
teachers
I
out
know.
there.
And the frontline workers, not just the people who are in the health field, but as we mentioned, even the funeral people, they've got a very high death rate, which brings me back to my final point, is that the other rituals that have been really difficult to miss are the sad ones, like funerals.
Yeah.
Because that's a time that we come together to support each other. Anyway, Jehan, thank you so much for inviting me. It's been a real pleasure. And
thank you so much for all of your work. And thank you to everyone for tuning in. We've got some great comments rolling in on the side there. Thanking you for all of your amazing knowledge that you shared with us today. I want to thank everyone again for joining us. This year, we're really looking forward to doing a lot of wonderful things at ADC, and hopefully we'll be able to host one of our conferences in person, hopefully in the fall, if we can get vaccinated and kind of control what we can do. But again, what you said, Dr. Bayoumi, is very important in terms of taking care of ourselves. I have a lot of friends who will reach out and say that they're so burnt out, they're feeling fatigued, they don't know what's wrong with them, and they feel like it's an anomaly. They feel like they're the only person feeling that way. I myself go through spurts where, like, 1 week I'll have so much energy, and the next week I'm like, I can't believe we're still at home, and I can't believe I can't see certain people. And yeah, it's important. I love to cook, so I'm always cooking tons of food, and that makes me happy. So I feel like people should just be looking for something,
I'm going to do a true confession for all the people on this webinar. This morning I had a meltdown, boohoo, ugly crying.
Yeah.
And I think it was just, and I felt better, by the way, because when you cry, for the men out there that hate seeing women cry, tears of joy versus tears of sadness or anger, do you realize that there are toxins that we release and it's different? So yeah, I feel a lot better, but yeah, it's hard. It sucks. Let's be honest. It's horrible.
Yep.
I miss my friends. I miss hugging. I miss seeing people. I miss
big gatherings, just like conferences. Dancing. Yes.
And Depka.
Yes, so much. I used to teach a Depka class in DC, and I really miss doing that. There's a lot of things that I know that a lot of people just, you see these old photos and videos and you're like, man, I really, it's great we have those memories and it's great to look towards the future, but in this moment, sometimes it is a little overwhelming. So I'm glad that you were able to tell us.
Oh, yes. But don't you think it's weird now that when I watch movies that were made pre-COVID, I'm like, why are they not wearing their masks?
My big thing is blowing on birthday cakes will never happen again, ever in the future.
It will.
I can't imagine seeing someone blow on a birthday cake and then eating a slice.
No, but I want to remind you, remember the influenza pandemic of 1918, and guess what happened after that? It was the Roaring 20s.
Right. Exactly. Yep, absolutely. So hopefully better times ahead.
Inshallah.
Hopefully everybody enjoyed this webinar. Please stay tuned and follow us. Make sure you sign up for our newsletter, adc.org. Donate and become members. There's a lot of benefits to becoming members of ADC. Last year was our 40th anniversary. So now we're rearing to go straight ahead into another 40 years, and with all of your support and help. So thank you to everyone, especially my staff working behind the scenes and our board members. And we've got some good stuff coming up in March for Women's History Month. We're going to talk about a very strong, empowered Arab women. And then April is Arab Heritage Month, and we will be celebrating our culture and our achievements as a community. So a lot of good things coming up. So stay tuned. Thank you again, everyone. Thank you, Dr. El-Bayoumi. And we'll see you guys next time. Have a great afternoon.
أي خدمة. سلامات everybody.
مع
Stay
السلامة.
safe. الله يسلمك. شكرا.